Hi everyone, my name is Faustine Ramirez and I'm a master tutor with MedSchoolCoach. Today we'll be reviewing a Step 2 CK medicine question. So let's get started and read the STEM. A 72-year-old man presents to the emergency department an hour after the onset of severe chest pain radiating to the back. The pain started suddenly while he was gardening. He has a history of hypertension, coronary artery disease, and prior myocardial infarction. He has smoked one pack of cigarettes per day for as long as he can remember. He appears in moderate distress. Heart rate is 108, respiratory rate is 22, and blood pressure is 168 over 102. A grade 2 out of 6 diastolic decrescendo murmur is heard at the right upper sternal border and intensifies when the patient is sitting up and leaning forward. A chest x-ray is shown here. Electrocardiogram shows sinus tachycardia and no ST segment elevations. Which of the following is the most appropriate initial step in pharmacotherapy? So I would like you to pause the video for a moment and try to work through this question on your own first. All right, welcome back. So let's approach this question together. So as always, our first step is going to be to read the question itself. Which of the following is the most appropriate initial step in pharmacotherapy? So this question tells us that this is going to be a question about pharmacotherapy, so specifically about management, but which medication to use. And it's going to be a question where we need to identify the diagnosis in the question stem and then answer a specific question about the diagnosis. We can briefly glance at the answer choices. It should just take a few seconds, and we see these are all medications, and we don't really need to spend too much time looking at these. We see that some of them involve cardiac-related medications, but that's pretty much all we need to take away from that, and then we can read the question stem. And as we're reading, we're going to be thinking about what the diagnosis is, and then after that, we will be able to answer the specific question about the diagnosis. So let's highlight the key elements. A 72-year-old man presents to the emergency department an hour after the onset of severe chest pain radiating to the back. The pain started suddenly while he was gardening. He has a history of hypertension, coronary artery disease, and prior myocardial infarction. So when you're reading past medical history, important to highlight those elements, especially if they seem relevant to the question at hand. He has smoked one pack of cigarettes per day for as long as he can remember. He appears in moderate distress. Heart rate is 108, respiratory rate is 22, and blood pressure is 168 over 102. I also recommend highlighting all the abnormal vital signs. A grade 2 out of 6 diastolic decrescendo murmur is heard at the right upper sternal border and intensifies when the patient is sitting up and leaning forward. So when you read these descriptions of murmurs or exam findings, sometimes it requires you to kind of put the pieces together and interpret what they mean. So murmurs are a great example of that, where they would give you the description of the physical exam finding and you have to interpret what the buzzword or what the specific exam finding is. And they'll do this all the time. So they might not tell you that the patient has thrush in their mouth, but they might say that there are white plaques on the tongue and in the cheek. Or another example here, they might give you the description of the murmur and you have to interpret to know what type of murmur it is. So let's point out a few things here and let's interpret this murmur. So it's 2 out of 6, which is not very high grade, but it's diastolic. So it's certainly concerning, right? All diastolic murmurs are very concerning. It's decrescendo, so that helps with the description, and it's heard at the right upper sternal border. So let's start with that. So when you think about our most common diastolic murmurs, we really only have a few options. And so one of those options, and we think about where this murmur is located, right? The right upper sternal border, that is the location that corresponds to the aortic valve. So right upper sternal border, we're thinking aortic valve. And then when we're thinking about diastolic murmurs, there's only one murmur that is diastolic that's heard at the location of the aortic valve. And so you may remember that this is aortic regurgitation. So it's useful to think, you can either think about systolic versus diastolic and then look at the location and see which one corresponds, or you can look at the location and think, okay, based on the location, I only have a few different options. And so what is the diastolic murmur that corresponds to the right upper sternal border? And so this is one of the more common murmurs that you'll be tested on. So you do need to know that aortic regurgitation is a diastolic murmur that's heard at the right upper sternal border. And it also has this quality of having this decrescendo quality. Now, this intensification when the patient is sitting up and leaning forward, this is also a clue. This is also classically seen in aortic regurgitation. So you may not have such a nice description of this murmur. You might just have a few features, right? You might just be told that it's diastolic, and you might not be told it's decrescendo, or you might just be told it's 2 out of 6 right upper sternal border that intensifies when the patient's sitting up and leaning forward. So I would definitely memorize this and know that this is associated with the aortic regurgitation murmur, because sometimes you might not get as many pieces of the puzzle. And so to identify what the murmur is, you might just have one of these elements. So I would know all these elements being associated with aortic regurgitation, and this is a nice clue in case you see it in a question later on. All right, so let's keep reading. A chest x-ray is shown here. Electrocardiogram shows sinus tachycardia and no ST segment elevations. All right, so let's take a look at this chest x-ray. And the one thing that should really jump out at you from this chest x-ray that you should be able to recognize if you see a similar example of this in a different question is that we see a really pronounced widening here of the mediastinum. And so this mediastinum here is much wider than it should be. And so this is an x-ray that is the classic x-ray for mediastinal widening. So if you do see this x-ray, you should be able to recognize it in the future. And finally, we're told about the EKG and that it just has sinus tachycardia, but no ST segment elevation. So which of the following is the most appropriate initial step in pharmacotherapy? So this is a great example of a question where we need to first identify what the diagnosis is and then answer a question about that. And so for these complicated questions with a lot of findings, different testing modalities that are involved, I think it's really helpful to take a moment to synthesize what we've read and synthesize those highlighted elements and put them together. And you can either put them together in your head, or some students like to just jot a few bullet points down. And when you focus on those elements, you kind of jot a few things down, there are certain patterns that emerge that might not emerge right when you're reading the stem. Now, this stem might be obvious to some students, but for some students, they might need to take a few moments to look at these different pieces and put them together. So let's do that step together. So pulling out the most important pieces from this question stem, we have acute onset of chest pain. And it seems like it did happen in the setting of potentially some exertion, but that's a very nonspecific finding and unclear how vigorous this gardening was. So I don't think that's certainly a defining feature. The radiation to the back, however, is a defining feature, right? So when we're thinking about chest pain, we want to think acute versus chronic. We want to think radiation. Does it radiate to the left? Does it radiate to the back? Does it radiate anywhere else? And so radiation to the back is certainly going to be one of the defining features here. So radiation to the back. Okay. Then we keep reading, and he has this history of hypertension, coronary artery disease, and prior MI. So of the things that present with acute chest pain, the things that I'm already thinking about are going to be MI, are going to be a PE potentially. It could be something that happens this suddenly. There aren't that many options. Could also be a vascular problem. And so here, this patient has a lot of vascular risk factors. So we'll put hypertension and prior MI, although in this case, this might just be a distractor. This patient has elevated blood pressure that's consistent with what we were told already. He has hypertension, although one would assume that his hypertension would be better controlled if he was on medications, but we're not told about his medications. So this is his blood pressure, it's very elevated, and we just take it at face value. He also has an aortic regurgitation murmur. And finally, we're given this chest x-ray with the classic finding of mediastinal widening. So when we're thinking about our differential for sudden onset acute chest pain, certainly MI in a patient who has coronary artery disease, several risk factors, and a prior history of MI is very high on the differential. Well, we're given the results of the EKG and we are told that there are no ST segment elevations. So although we could have been concerned about that initially, once we see the results of that EKG, we can cross that off the list because if this truly was an MI, there would be more abnormal findings on the EKG besides just sinus tachycardia. And ultimately, this constellation of findings with acute sudden onset chest pain radiating to the back in a patient with very high blood pressure, a new aortic regurgitation murmur, and a wide mediastinum. This is the classic presentation for aortic dissection. So when I think about radiation to the back for acute chest pain, aortic dissection is at the very top of my differential. Other things that can radiate to the back, you could think about pancreatitis, although that might not present so acutely within a 1 hour sudden onset time frame like that, but certainly it could within a few hours. So that's still on the differential. In a more subacute presentation, you could maybe think about GERD or peptic ulcer disease, but this presentation is really a slam dunk for aortic dissection. So now that we've identified what the diagnosis is, then we need to be able to answer a question about this diagnosis. And the question here is specifically referring to the best initial step in pharmacotherapy. So not only do we need to know about the management of aortic dissection, but we need to know specifically um, medications that we need to use. And we're talking about very specifics here. We're looking at do we use nitrates? Do we use nitroprusside, hydralazine, furosemide? Very specific medications here. And so let's take a moment to learn a bit more about aortic dissection and kind of delve into these details that are required for the Step 2 CK exam. So in aortic dissection, there are a number of risk factors. The most important one, first and foremost, is going to be poorly controlled hypertension. Um, in younger patients, especially patients under 40, you might think about collagen disorders. Um, Much less common, but tends to pop up on the boards, is patients who have a history of syphilis, who have aortic aneurysms, patients who use cocaine, or who have bicuspid valves. But first and foremost, poorly controlled hypertension is going to be your number one risk factor. This is going to present with sudden onset of very severe tearing chest pain radiating to the back. You might have asymmetric blood pressure in the upper extremities. So the right and the left upper extremity blood pressures may be different. You can have a new aortic regurgitation murmur, and that's specifically in an ascending type. And we see here type A would be considered ascending. So if it involves the ascending arch here, it's a ascending dissection, versus if it just includes the descending aorta, it's going to be a type B. And the management is slightly different, and so it's important to know which findings would correspond to which type. So if it's involving the aortic root and causing aortic regurgitation, it would have to be an ascending dissection. And so if it's ascending, even if it involves the descending aorta, if it does have any ascending involvement, it would be considered an ascending dissection, versus if it has to be exclusively the descending aorta for it to be a descending. So important to pay attention to the symptoms that the patient presents with, because this can clue you in to where the dissection is located and whether it's type A or type B, and the management will differ. Other complications can be a stroke, can cause MI, an ascending type can cause MI, pericardial effusion or tamponade, you can get a hemothorax, and then some of these other complications like leg ischemia, bowel ischemia, or renal ischemia would be more involvement of the descending aorta. And so depending on what other symptoms you have, it'll clue you in to whether it was ascending or descending. Now, in terms of management and diagnosis, so on chest x-ray, the classic finding is going to be a widened mediastinum. And like I said, you should be able to recognize this image shown here. You should be able to recognize an x-ray of a widened mediastinum. And CT angiogram is going to be the best test, but only in patients who are stable, who have good renal function. So if it's a question about diagnosis and you're asked what is the best next step in diagnosis, You have to pay attention to the hemodynamic stability of the patient, as well as whether they had a history of CKD or if their creatinine was elevated. CT angiogram is going to be your best diagnostic step. Again, like I said, if the patient is stable and if they have good kidney function. If not, you should be using a transesophageal echo if they are hemodynamically unstable, if they have an allergy to contrast, or if they have poor renal function. And although these seem like very small details, they are tested. And so when you have a question about diagnosis, pay attention to kidney function and stability, because you may need to differentiate between CT angiogram and TEE, and you will need to pay attention to these small details. Now, management, this is where this question really wanted you to know details about pharmacotherapy. So the first step in pharmacotherapy will be to give an antihypertensive, and IV labetalol is going to be your first line antihypertensive in aortic dissection. Now, if the patient does not respond to IV labetalol, you can add nitroprusside second, if needed, but you never want to give nitroprusside first because there's a risk of rebound tachycardia. And these patients are often already tachycardic, and their cardiac function is impaired. And so we don't want them to have rebound tachycardia. And so IV labetalol is going to be your first line antihypertensive. And again, this seems like a small detail, but you are required to know this level of detail, because you really want to avoid this risk of rebound tachycardia. And then the management depends on whether it's an ascending or a descending dissection. If it's ascending, it's a surgical emergency. And so you should know that this would be the next best step if asked. And then for a descending aorta, the indications for surgery depend a little bit on whether there are signs of organ malperfusion. So if there's evidence of leg ischemia, if there's evidence of bowel ischemia, or of renal failure due to renal ischemia, those would be indications for surgery, but not all patients with a descending aorta need surgery. So it depends a little bit on what the other parts of the presentation are, but certainly you will be tested on the fact that an ascending dissection is a surgical emergency, and you will be tested on the fact that all patients, whether ascending or descending, need an antihypertensive, and IV labetalol is first line here. So if we take a look at our answer choices again, we can work through these. So sublingual nitroglycerin, this might have been helpful if this was a presentation for MI, but as we've learned, this is an aortic dissection, so that's wrong. IV nitroprusside, this was testing your knowledge of the fact that nitroprusside should not be given first, right? Not the initial step. It might be useful after labetalol, but you would not give this first, so this is wrong. IV hydralazine is a different antihypertensive, but it's not used in the setting of aortic dissection. It's not the initial first step, so that's wrong. Oral aspirin would have also been helpful in the setting of MI. And this question was really trying to trick you into thinking this might have been MI because he had a history of prior MI, and this was acute onset chest pain. But if you knew enough about the constellation of findings, you knew that this was aortic dissection instead. Subcutaneous heparin, also not part of the management of aortic dissection. This was kind of here as a red herring. For example, if you were thinking this might be PE with the chest pain, tachycardia, tachypnea, if you were going down that path, you might have been fooled and you might have wanted to pick heparin. But there are too many other findings that are consistent with dissection. So PE is not consistent here, and so we can cross that out. IV furosemide, this might have been helpful if you were thinking that the patient had pulmonary edema, maybe had respiratory distress because of flash pulmonary edema. Maybe you misinterpreted the chest x-ray and thinking that there was fluid in the lungs. So again, here as a red herring to distract you. And then finally, IV labetalol, which is the answer that we're looking for now that we know this is the first line antihypertensive in aortic dissection. So this is a high yield subject. You could be tested on the diagnosis aspect of a dissection. You could be tested on pharmacotherapy aspect, on the surgical management. You could also just be tested on the identification of this disease. And so it's really important to know all the aspects that we discussed. And I hope that after this question, you'll be able to master all questions on aortic dissection in the future. Thanks so much for listening. That wraps up our question of the week.